Now that we have understood the orientation, the anatomical landmarks, the surface anatomy, and the muscles acting at the scapular region and superficial back, now it's time to take a look at something in depth, which is the association of the uh, movements which are occurring at different muscles, in which the rotator cuff comes into play, which is associated with scapula because rotator cuff originates from the scapula and acts at the glenohumeral joint. And glenohumeral joint, as we discussed in the previous lecture or previous section, is greatly associated with the scapulo-thoracic articulation movements in terms of scapulo-humeral rhythm. And this, when we take a look at biomechanically, this perspective gives us a coupling of different muscles which are essential for the performance of different movements and specifically the contribution of the scapula in terms of glenohumeral movement. So let's take a look at the muscles here once again. So we have the rhomboid major, rhomboid minor, the upper middle and lower trapezius, infraspinatus, supraspinatus, deltoid, teres major, teres minor, and here we have the levator scapulae, and that's pretty much the muscles that we have already discussed in the previous lecture. And here we have the deltoid, which is yet another important muscle. It is not a part of the rotator cuff, but it couples with the rotator cuff and is very important in the function when we're talking about the scapular region. And here we have the names of the different rotator cuff muscles, including the supraspinatus muscle, which is present just superior to the spine of the scapula and the supraspinous fossa. The infraspinatus muscle, which is located or lodged in the infraspinous fossa, just beneath the spine of the scapula. The trispinous muscle, which arises from the middle half of the lateral border or the axillary border of the scapula, and the subscapularis muscle, which arises from the subscapular fossa, which is located ventrally. So this muscle is located ventrally, the other three are located dorsally, and we can see the subscapularis in a much better view in this picture. And this is the ventral aspect of the scapula, where we have the subscapular fossa, and here is the subscapularis muscle. Here we can see once again this is the teres major, and here we have the subscapularis in the ventral aspect, and here we have the rhomboid major, rhomboid minor, and the levator scapulae. Taking a look at the dorsal aspect of the scapula, we can see the other three muscles of the rotator cuff, which is the supraspinatus, the infraspinatus, and the teres minor. Once again, this is the infraspinatus beneath the spine of the scapula. Just above the spine of the scapula, we have the supraspinatus. Here we have the teres minor, and teres major has been transected, so we can get a visualization of this. So teres minor, infraspinatus, supraspinatus located on the posterior aspect, making the posterior aspect of the rotator cuff, and the ventral aspect we have the subscapular fossa and subscapularis muscle, and these four muscles make up the rotator cuff, which are very important for the dynamic functioning and stability of the glenohumeral joint. So talking about the oblique rotator cuff muscles, as we can see in this picture, the supraspinatus is lying completely horizontally. All the other muscles are at an angle, including the infraspinatus, teres minor, and subscapularis. So their line of action of force is located at an angle or oriented obliquely, and that is why they are known as the oblique rotator cuff muscles. So when we say oblique rotator cuff muscles, so there are three muscles in it: the teres minor, the infraspinatus, and the subscapularis. Now deltoid actually couples with these muscles in a different way as compared to it couples with the supraspinatus. So deltoid and oblique rotator cuff muscles are responsible for the elevation of the upper extremity by making a force couple, because they have their forces acting in the opposite direction. How are they acting in the opposite direction? If we take a look at the deltoid when the arm is at the side, so the force of the deltoid is upward and outward like this. Whereas if you talk about the oblique rotator cuff muscles, their force is inward and downward. So deltoid has two components. The y component is upward and the x component is outward. And the oblique rotator cuff have two components. The x component is inward and the y component is downward. So because of these components, the superior component and inferior component, they actually cancel each other out, and the contraction of the deltoid does not result, or it doesn't result in the superior migration of the humerus and thus subacromial impingement. And that is one of the importance of these two muscles, or these two group of muscles actually contracting each other's action. But the other thing that we have is the horizontal component, which is inward and outward, and we are going to talk about that in detail. So this orientation, as I already mentioned, can be resolved into respective vertical and horizontal components, and as I already mentioned, that the Y component of both of these muscle groups actually cancel each other out, so there is no superior migration. However, when we talk about the horizontal component, then the inward component and the outward component actually create a force couple just similar as that in when you are driving a car and when you move a steering wheel. So horizontal force of deltoid acting below the center of rotation of the glenohumeral joint, and horizontal force of oblique rotator cuff applied above the center of rotation. So as they are not in line, they are just slightly above and below each other, so they create a force couple, and that results in efficient and effective upward rotation, or we can say elevation of the extremity. So powerful force couple, vertical forces offset each other, horizontal components make a force couple, and then that results in effective abduction movement at the glenohumeral joint. Moreover, deltoid also couples with the supraspinatus, but in a different manner. As we talk about the supraspinatus, when we have the supraspinatus, we look at the supraspinatus in the arm in the adducted position, we see that the orientation of the supraspinatus is in such a way that the abduction is initiated by the supraspinatus. And it keeps on going up till the 30 degrees, which is followed by the overhead abduction, in which the prime mover becomes the deltoid. This is because when the abduction occurs, so first 30 degrees is initially by the supraspinatus, then the deltoid starts playing its role as an abductor. But once the abduction reaches 90 degree, the long axis of the bone becomes parallel with the line of action of the supraspinatus, so it does not further helps in the abduction. Instead, it acts as a dynamic stabilizer by pulling the humeral head inside the glenoid cavity, whereas the deltoid then acts as a prime mover and causes further abduction at the glenohumeral joint. So patients with large tear of the rotator cuff can actively maintain the arm abducted to 90 degree because that action is of the deltoid muscle, but may not be able to abduct to 90 degree because of the weakness of the or inhibition or the loss of the function of the supraspinatus. Moreover, when we talk about the stabilizing action of the rotator cuff muscles, they have different angles of pull. So subscapularis and infraspinatus is almost 45 degree and teres minor is almost 55 degree, and that downward and inward action of the subscapularis, infraspinatus and teres minor complements and contradicts the action of the deltoid by creating an opposite line of action of the force to the deltoid, which is the outward and upward. So there is stability provided by the rotator cuff muscles in this manner. Moreover, these vectors result in nearly equal glenohumeral joint compression and humeral head depression, because the inward component pulls the humeral head inside the cavity and keeps it in this way, and the downward component pulls the humeral head downwards, which actually results in creating the space for the subacromial region, and the upward movement by the deltoid is actually contracted by this humeral head depression force created by the oblique rotator cuff. Moreover, supraspinatus is essentially horizontal in orientation, and it acts as you can say it pulls the humeral head inside the glenoid cavity when at the 90 degree abduction, and thus provides stability at the 90 degree abduction to the glenohumeral joint. And that was all about the coupling mechanisms at the glenohumeral joint in terms of scapula and its function and the muscles arising from it, and also the biomechanical perspective. I hope you learned something new out of it and it was beneficial for you. So keep on watching sqadia.com for more lectures like this. Thank you very much.